Afternoon. I am here representing the American Association of Neuroscience Nurses. I am here with Dr. Edie Zusman, and today we are going to be talking about traumatic brain injury with a very unique perspective, looking at domestic violence and intimate partner violence patient populations. So welcome, Dr. Edie Zusman. How are you today?
Hi, good. Thank you. I'm so glad to be here. This is such an important topic.
It really is. So we are very much looking forward to your expertise and for sharing your knowledge with us. I want to start with asking you what drew you as a neurosurgeon to focus on brain injuries related to domestic and intimate partner violence?
Yeah, I was, the chief of my program. I was working on program development, and we had a traumatic brain injury and concussion clinic. And, it's usually young men between the ages of 18 and 35 and high-risk behavior, sometimes with substances. And we were seeing as many women as we were men. And we were curious, like, why were we seeing so many women? This was just as COVID was starting.
Right, right. What is something that you wish nurses understood about how common this really is? And you
Oh,
said you were
gosh.
surprised at the numbers. So, yeah, what would you like us to know?
Yeah, really powerful. So even if you use just the highest level statistics of reported events, we're looking at between 10 and 20 million events of intimate partner and domestic violence a year. And we understand that 80% of those from Eve Valera's work at Harvard involve injury to the head and or neck. And when we think about that, and then there's additional statistics that say that if you're currently in a domestic violence relationship, there might be an average of 17.2 events per year. So for me, what drew me to this was thinking we look at football and we look at sports, and when I take care of my athletes, if they have a concussion, I don't let them go back and play until we know that they're recovered and clear. And then you think about somebody in a domestic violence situation who doesn't know they're brain injured and isn't getting the care, and they might get another brain injury, and they might have so many demands on them that they're not really able to, you know, function like that. I always imagine one of the football players post-concussion getting like a newborn baby to take care of. And you say here. And that's what's happening in homes around America and around the world.
It really is shocking. Um, what would you say are some of the most common but overlooked signs of traumatic brain injury in patients who are experiencing this intimate partner violence?
Yeah, and so we're all blind to this. The doctors, the concussion experts, our family practice and ER docs, and even the patients themselves. So they'll come in with symptoms that might be occipitocervical headaches. They might come in with symptoms of depression, anxiety, PTSD. One of the really prominent symptoms is a feeling of hopelessness. A lot of the symptoms of TBI, as we well know, look like mental health symptoms, but in the context of TBI, we know that it's the effect of the brain injury that's causing so much of that.
And these can go on for a prolonged period of time, right? And
Yes,
unrecognized.
they can go on, they can be cumulative, and then we think because of the frequency and the lack of, the pause to heal before another event, that they may end up having more of a second impact type of scenario where the injuries can stack.
Okay, so that actually leads into my next question, which is how does repeated non-accidental head trauma from intimate partner violence differ neurologically from those sports-related injuries?
Well, we did a study in my clinic, and we looked at all of our patients and divided them by mechanism, if it was DV and if it was any other type of head injury. And the two groups were identical in terms of all of their objective metrics, their imaging studies. The biggest difference was that the women came in with 6.2 average brain injuries before referral, and the men had an average of 2.7 lifetime injuries before referral.
Wow.
The difference for the timing of referral The men were coming in within about 6 weeks of the injury, and that makes perfect sense, right? Because if it's just a mild concussion, you'd be better at 6 weeks, and so they were sent for a higher level of care. The women came in after about 6 months of symptoms. So we are definitely seeing some really important information from the data.
I mean, aside from the obvious things, what do you think is also contributing to such a prolonged time before they're coming in for care? Do you have any information on that?
Well, I can tell you this from my own experience. I went to a great medical school, Northwestern. I did my neurosurgery training at UC Davis, my fellowship at UCSF, and we were literally taught that when a woman comes in wearing dark glasses, we should think about domestic violence because they might be embarrassed or, not able to cover or bruising with their makeup. And on the same clinic day where I saw a gal come in with that scenario, I saw a gentleman come in wearing his, workout clothes, wearing his dark glasses in the clinic. And I said, "Oh, I'm such a good doctor. I bet that's a concussion. I bet he has photophobia, light sensitivity from the concussion." And literally, it was like a visceral aha moment. If I was one of the first 100 women neurosurgeons and I was giving the woman patient a mental health diagnosis of, feeling bad about herself, poor self-image, and I was diagnosing the man with the hallmark of concussion, light sensitivity. So
That's
believe
really
me,
profound.
it was such a profound experience for me. Like, how could I be part of the problem? And it just made me realize that if I was missing this, that there probably, were other folks who were seeing the same constellation of symptoms, but dividing them up between concussion and mental health.
I love that and appreciate you sharing that vulnerability with us. One of the things that we aim for in the advocacy committee is to promote areas where we may have those unconscious bias that we're
Right.
not aware of. And so this is an area that I'm so happy that you're able to help shed light on, so we can be self-reflecting, in our own practice. Often nurses are the first clinicians to interact with survivors. So what specific screening questions or assessment techniques do you recommend nurses use?
Well, I think we have to always keep in mind that there are essentially three different types of brain injuries. We always think of, hits to the head or the head being hit into something. I think the ones that we aren't counting in this population in the same way are the ones that are whiplash induced. So there can be a lot of shaking. There can be a blow to the jaw that causes an angular stretch at the occipital-cervical junction. And so I think we need to make sure to ask about all different types of events related to injuries to the head and or neck. And then the one that's becoming more and more common in this population, it seems to have been almost mainstreamed also during about the time of COVID, but it's the effective strangulation, and that can be with
Right.
hands or ligatures. So we always want to ask some of those details. Some people will say I was choked. We don't need to correct them and say, well, you really weren't really choked, you were strangled. We can just accept that they're sharing just very precious information with us and give it the respect and the dignity of the openness. But it looks as though where the brain injuries from the strangulation may actually be due to bilateral venous occlusion with elevated intracranial pressure. I get to talk about this with you guys because you know what I'm talking about.
Yes.
And so when the ICP goes up, right, then the cerebral perfusion pressure drops. We're not getting as much blood flow to the tissue of the brain. And so we think there's a really strong mechanism with just the most mild bilateral venous occlusion. And anybody working in the ICU or with patients with intracranial pressure monitors, ventriculostomies, you guys know what happened if we increase the PEEP, if we tie the ET tube on too tight, if the head is kinked. So all of those are happening. The other piece of information that we have, and then of course, if there's more pressure, it's bilateral carotids. And if there's more pressure, it can be primary occlusion of the airway as well. So all of those are possible. I just wanted to call out the fact that it can be very mild occlusion. You and I, Jenny, we can hold our breath underwater for a minute easily, but folks will pass out with somewhere between 8 and 10 seconds
You
of
answered my question, my next question. So thank you. Yeah. Can you
looks like
speak
the
a little bit more
chokehold.
to that? So a brief period of time with very mild pressure can cause injury. You
Can
said
cause
8 to 10 seconds.
8 to 10 seconds. And some of the literature comes from the information we have about chokeholds, with a lot of our military and first responders did in training. And unfortunately, some kids like do it as part of martial arts, and they might even do it on the playground because they think it's funny and amusing. But I think the key is that for those of us with the TBI experience, like the AANN nurses, um, if we have a TBI patient who comes in from a car accident or a fall or a sports injury, one of the most important predictors of neurologic outcome is any episode of hypoxia. If there's an additive insult of loss of good oxygen to the brain, as well as a primary injury, we know that that seems to potentiate. That is multiplicative. So
Right.
here we are with a population who, might be having injuries to the head and being pushed down and having events like strangulation. So it once we open this understanding, there's just so much that we can bring behind it because we actually already know all the pieces.
Absolutely. Can I ask what role trauma-informed nursing care plays when supporting patients with supposed or suspected domestic violence related injuries?
Yeah, 100%, right? Trauma-informed care is providing the best care for that human being who's with us wherever they may be. And what we think will be the future of trauma-informed care in the next generation, it's going to be brain injury aware trauma-informed care. And I think that's what we would want to collaborate on to make sure that all of us who know these high-risk populations are bringing our knowledge of brain injury into the trauma-informed care we're currently providing.
Great, thank you so much. Through your work with Safe Living Space, what gaps have you identified in nursing education related to the brain injuries and domestic violence?
Yeah, I founded Safe Living Space because I felt like if we just published papers and went the academic route, it would be 20 years before we got the help to the individuals who need it today. So I think that's the most important thing. And I don't need a full history of who hit the person, or, if they say that they fell down a flight of stairs, for the point of view of doing a good neurologic evaluation, that's what we need. We need to
Right.
know. And there's a lot behind that. There are the psychosocial factors and are they safe now? But from the perspective of just doing a good assessment to see if there could be a brain injury, we can do that without getting the whole story. On the other side of that, if we take a history and there's a gap in the history, and we were talking about this before, Jenny. First, the patient was upstairs, and then they remember being
Right.
downstairs, or first they were outside, and the next thing they remember is waking up in their kitchen. Um, those are gaps in the story. And if we take that history from a grandma picking up her kids at church preschool, if she's intending to make a left turn, puts her signal on, and then the next thing she remembers is the paramedics knocking on her door. We know she was, hit by the oncoming traffic making that left turn. We look at that as the length of anterograde amnesia, as the loss of acquisition of new memories. And we actually use that to determine how severe the brain injury is. Currently, when some of us are taking histories, either forensic nurses or first responders, or even some of us in our own offices, we hear that story and the first thing we think of isn't, that's the brain injury. I see it. I see that gap.
Yeah, what do you think is the first thing that comes to our mind? Where does our mind go when we hear that?
Well, I can say that right now we did some work with Track TBI and looking at what happens in the trauma system. And so it looks as though when folks come in, they come in with their mechanism of injury already on the trauma referral. So somebody who comes in from, a high-speed car accident, there's a protocol. If someone comes in with traumatic, with DV/IPV on their intake, almost the first person they see is the social worker. They get a very tertiary screen of whether they need to be admitted or not. There's a decision about whether they need a CT or not. But you and I know that there's a lot more to understanding TBI than than the emergency triage.
Right, right. So, how can we address those gaps in the curriculum as institutions, as medical
Yeah.
establishments? How can we fix that?
And that question means so much to me because yes, I think there are gaps in all of those levels. So I think together, the beauty of AANN is it's a national organization. There are nurses in every state and almost every city who have neuroscience knowledge and can speak to this. We don't have to do any additional training per se. We just have to do what we always do for TBI and apply it to these new high-risk populations. And the populations are domestic intimate partner violence, the sexual assault, um, rape circumstances. We're worried about folks in foster care, the trafficking population. And so we just want to recognize that there are folks in high-risk populations where we need to pause. And even if they don't need an emergency CT scan or a neurosurgery ICU admission, we need to think of them as potentially having sustained a brain injury. Statistically, over 80% of them likely have at some point, whether it was now or within the last year. And we need to break that down and help them understand what's happening in their body and get the right kind of evaluation and follow-up they need. I'll give just a couple quick examples.
Yes, thank you.
Like if you see somebody following a car accident and they tell you, that they're just so stressed, they always see cars coming into their lane and they don't like driving anymore. Right now, that gets diagnosed as PTSD or you're triggered because you had the car accident. We've been seeing folks with whiplash mechanism injuries, the occipitocervical stretch injuries on the continuum of diffuse axonal injury from that type of mechanism, and they have abnormal near point convergence. You hold up your finger and you say, everybody sees double at some point, and you say, I'm going to walk my finger toward your face. Tell me when you see double. And these folks who've had whiplash-induced brain injuries, they'll be like, right about here, doc. And then I always go out and I say, okay, is it one now? Tell me when it's one. Let me try it again. Is it still turning into, two right about there? Yes, yes. And so you go ahead and measure that distance to the nasion. If it's greater than 6 centimeters, that's abnormal. And we're seeing folks with like 30 centimeters. They are seeing cars coming into their lane.
Absolutely.
And so that's an example of places that we can really bring our neuroscience knowledge into care. You and I talked about, it's not mental health if you get dizzy shaking your head. No,
Right,
it's not
right.
mental health if you look like you're on a boat and you feel like you're swaying when you close your eyes. So there's a lot of other things this could be, but I think those would be three very basic, simple things that we might test anyway, but now we're testing it from the perspective of could there be an unrecognized brain injury?
Do you think, from an interdisciplinary approach, who would be those key players that we would say flag and call in to help us tackle this?
Yeah, I might need a little bit of a reframing of the question, but I
Sure.
personally believe that to answer your initial question which is like, how do we spread and scale this? How do we get this information everywhere it needs to be? I think if we can train our neuroscience nurses, I think they're the ones who are going to see this first. They're the ones who are going to be able to look beyond the fact that, somebody may look, disheveled or they may be crying or emotional up and down. That's a TBI too. If somebody's laughing and then crying and they're like, Doc, I don't really know why my emotions go up and down like this. That is part of the behavior that we see with TBI. So I think if we can bring our hearts and our compassion as well as our brains, I feel like together we can probably make the biggest impact on this.
Absolutely. And so recognizing it initially is probably one of the most important parts of it. And then we typically would have our resources there. So I was asking, like, outside of social work, who else might we expect to be part of that patient's care once we identify that we have a domestic violence traumatic brain injury?
Yeah. Well, we have to build up capacity because right now, the majority of TBI clinics in the United States are really very geared towards sports. And so we have the knowledge around sports. But like, I remember a patient who was a very accomplished attorney, and her professor husband beat her incessantly for about 20 years of their marriage. And by the time I saw her 20 years later, and she must have been just brilliant, she perseverated. She would stick on a topic, she'd bring in her papers, and she'd say, I have to get my papers completed. And you'd say, okay, Mrs. So-and-so, let me go through some of these exams. And she'd be like, but my papers aren't completed. And I didn't understand what it was, but it was cumulative brain injury, where you're stuck somewhere and you're unable to make that transition. I saw a gal who had military sexual trauma, and I saw her once and we did an initial evaluation and I thought we had some good rapport. And so the following week when I saw her, I sort of picked up where we left off. I was like, well, hello, we'll call her Robin. I'd say, hello, Robin. So good to see you again. What ended up happening with this, that, and the other? And she looked at me and she was madder than piss. And she's just like, why are you talking to me like you know me? I have never seen you before, lady. And what was that? Short-term memory. She didn't remember what had happened the week before. And that's not substance abuse or drugs and alcohol. It's a very severe TBI that involves, as you know, changes to the bilateral temporal lobes, which we see frequently. Somebody can fall backwards. They can be pushed out of a moving car, like one of my patients was, and hit the back of their head, have bitemporal contusions. A lot of those folks have short-term memory issues. So I think that just having that curiosity and that sense of who is this person who I am privileged to care for, and then just let them tell you who they are, let them tell you their story. But we want to keep our expertise. We want to keep the clarity of, could there be a brain injury behind what we're seeing?
Absolutely. And we could probably get down a whole nother tangent of where the physiological trauma meets the emotional trauma and the cognitive issues that come with both. And just again, how profound it is that you can take these very intelligent people who just get stuck and you see the result of it. It's really sad and difficult to work through. Do
I
you
have
have
to
any?
say, just
Sure.
just to pivot to the positive note on that,
Yes.
I feel like so many of us have played sports. Our kids have played sports. We're trained in concussions. We watch it on football. So we know a lot about concussions. And my hope and, if you will, prayer is that someday, by helping somebody see that it's not just a bruise and it's not even just a broken bone that'll heal, that it's your brain and you only have a few chances to keep that brain healthy and whole. I hope that just by doing that education, which we would do naturally with
Right.
that knowledge, that will help people be safe and let their brains heal.
Do you have any final messages for nursing professionals to take away about this unique power that they have at the bedside or in their interactions with these patients?
Yeah, I just think we can do it, and we have the knowledge, we have the trust of our patients. They're going to tell us the truth. They're going to
Right.
tell us what we need to know to take care of them. And I think with that is an opportunity. We need to keep in mind that right at the event, when a lot of us might see somebody in an emergency room or in a forensic environment, you've got your adrenaline, the inflammatory changes haven't yet taken place. So we always want to say to somebody at this time, and we want to document at this time, we're not seeing this, that, or the other, but a lot of folks end up showing their symptoms, right? We all know the highest rate of brain swelling is like around that 3-day period. That's where we're cautious with our intracranial hemorrhages to see whether they're going to get away without a surgery. And the same is true for TBIs. So right at that 3 to 5 day range is when a lot of our patients come forward with their symptoms. So I think one of the other things that I always try to do is arrange follow-up and make sure that they have an appointment to see a provider who is trained in traumatic brain injury, who can do that follow-up assessment.
Any other final thoughts?
Just thank you. I think this is such an important issue. I think it's going to save lives, save quality of life, and I think this conversation is going to end up being relevant to a lot of individuals who've experienced physical violence and whiplash type of injuries and strangulation types of injuries who aren't currently being seen in our healthcare systems.
Absolutely, I agree. Dr. Zussman, thank you so much for being here with us today and sharing your perspective. I anticipate this will probably become a bigger conversation and hopefully we can spread the awareness and really take action.
Oh, that would mean the world to me. Thank
Thank
you.
you.